Howdy YouTube family, it's Bolt SRNA coming to you again with another day's topic. Today I want to talk to you guys about 5 things that I have learned since I've started my anesthesia rotations. A lot of you probably heard a couple weeks back, well about a month or so ago, I started my anesthesia clinical rotations, and I have learned quite a few things, but today I wanted to sum them up into 5 different things that you guys could learn from and grow and maybe step into CRNA school a little bit wiser than I was, and it might help you out. Let's get into it. Okay, so the first thing that I learned is that anesthesia is just as much an art as it is a science. Especially if you're in a DNP program, you're going to spend your whole first year just cramming in the books and learning so much information. You're going to be memorizing the milligrams per kilograms of all the drugs that you're supposed to give. You're going to learn how to do fluid resuscitation calculations within the first hour and second hour, depending on how many hours they were in PO. Is it an open belly procedure? How much blood loss they've had? Is the lap sponges 3/4 filled with blood or not during the surgery? How to equate that to milliliters of volume you replace. Tons of calculations that you learn in school. And then you will find out, after slaving over your desk for hours and hours and hours and days of memorizing this stuff, you'll get into clinicals and realize people don't do that. People don't do fluid calculations. They turn on the LR and they just kind of titrate to effect. With some reasonable clinical knowledge in their head. They don't overload a CHF patient or, a robotic prostatectomy. They're not going to flood with a whole bunch of fluid. But as far as like having hardcore calculations, most of them don't do that. Another thing is you'll find a lot of the information, like if they are bradycardic or anything less than, say, a heart rate of 70, in the books, you would immediately, like on a test, you would never answer that you would give phenylephrine for that patient because of the risk of reflex bradycardia. But in clinical practice, you'll find some people will give phenylephrine and they'll give ephedrine with it to counteract for the ephedrine to give the beta effects and the phenylephrine to give some alpha effects, and it to counterbalance each other so you don't get reflex bradycardia, they feel. Now, that's not something you learn in a book. And so there's no way to really prove. I mean, I'm sure you could run studies on it, but I've not seen anything proving that one way or the other. But you'll find in clinical practice, anesthesiologists and CRNAs, they do all kinds of things that are kind of not by the book. So realize that you're going to study a lot of information before you start clinicals, unless you're in a master's program that throws you into clinicals very fast. But if you're in the doctorate programs, which everyone's transitioning to, you're going to do a lot of academic learning your first year, and then you're going to realize it does not all go that way when you get into practice. Second thing that I learned that was important to know is that every anesthesia provider is a little bit different from the one you had yesterday. And when you're doing rotations, you're not going to be with the same person every day. It's going to be different people day to day. Sometimes you might even do the first 2 cases of your day with one anesthesia provider, and then the next 2 or 3 cases of the day you might be with somebody else. So you'll get the idea of how different people practice throughout your day and every day during your rotation. But the problem with this is they all practice a little bit differently. So you're going to learn really fast how one provider is going to use the MAC blade on every patient, unless it's something that requires a gyroscope or something. But in general, if it's a normal intubation, they're going to use a MAC blade. And then you'll go your next day and be with a different person, and that person always uses the Miller blade. They always use Miller, and they never use MAC at all. And you're going to find out that they're going to want you to use the Miller, so you're going to have to adapt to that. There will be some people who will put lidocaine jelly on the tip of the ET tube because they feel like it softens up that area and doesn't make it hurt as much when they intubate, and then during extubation the patient in PACU doesn't have as much soreness in their throat, things like that. And then you'll have another, I had one person who really hated that I prepared the ET tube with a lubricating jelly and actually threw it away and got a fresh one out and said, we're not going to do that. So you'll find that some people really do not like the way that you learned to do it yesterday from another provider. And of course, none of it is wrong. Like in anesthesia, there's so much that you can choose based off your own opinion on things, on how you want to do it. But you'll find that other person the next day doesn't like it that way. So you're just going to have to learn to roll with the punches, and you'll find there's 100 different ways to do it, and you'll figure out which person wants you to do it which way, and you'll try and do it that way and adapt to their style. That one kind of leads me into my third thing that I learned pretty fast. You need to get tough skin pretty fast in anesthesia. You'll find that anesthesia providers, CRNAs, and anesthesiologists are some of the most OCD people you'll ever meet. And if you're going into this field, chances are you are probably pretty OCD, and you are probably pretty big control freak, and you probably like to have things exactly the way that you like them, lined up in a row with everything, going in a sequence of how you want it. And that's the same way that anesthesiologists and CRNAs are. And that's partly what makes them really good at their job, because if you keep everything exactly routine and very controlled in that environment, your likelihood of having complications is much less than someone who has a more chaotic or less routine way of doing things, because things can go wrong, things can slip through the cracks, you can make mistakes if you're not very methodical in the way you do things. But the problem for you as a student is you don't know that person's methods. And you stepping in as a student, not being fully trained yet, of course you're a student, you don't know how to do anesthesia like they do. So you're going to make mistakes. You're going to put the laryngoscope on the right side of the anesthesia cart instead of the left side, and they like it on the left side, and they like their oral airway on the left side of that. And you're going to put the oral airway over here, and then you're going to draw up this induction drug because that's what you used yesterday, but you're going to find out that person doesn't like that induction drug, and they like their induction drugs set over here in this drawer, all prepared. So you're going to find out pretty quick they're very OCD, they're very specific on the way they want it to be done, and you are going to be viewed like a bull in their china shop. And some of them will have grace and mercy, and they'll remember when they were a student, and they'll take a breath, and you'll be able to tell that they're irritated at you, but they'll take a breath and they'll say, I want it done this way, and they'll show you that way, and they'll, you'll move on, and then hopefully the next time you'll remember that person wants it done that way, and you do it that way. There are some others that they don't have very much grace or mercy. They have a very short fuse, and they don't appreciate you being a bull in their china shop, and they'll let you know, and you'll have a very quick idea of what they think about you. And sometimes it might be some name calling, and sometimes they might degrade you a little bit and make you feel very small if you make a mistake, and they feel like that was not an excusable mistake, or I don't know, maybe they're having a bad day. You don't know. Sometimes people just have bad days, and you are stuck with that person pretty much as a new junior, doing CRNA school. You're going to be stuck with that preceptor like to their hip all day. You're not going to be out there doing all these things on your own without somebody near you. So if they're having a bad day that day, you're stuck next to them all day. And if they're not having a good day, and they're in a bad mood, and you're making mistakes and you're cramping their style, they may snap on you, and you just have to kind of deal with it. This is not like nursing school. You don't have a clinical preceptor who's there with you. You don't have a teacher from your university who's just hanging out on site with you just in case somebody's mean to you or something. You are there independently on your own. Maybe you're at a site 2 hours away from your school. You are there, learning underneath the CRNAs and anesthesiologists there. And so they're kind of like your boss for the day. And if they're kind of mean to you or whatever, you just have to put up with it and deal with it. So the main third thing that I learned is get some thick skin. Learn how to be silent a lot of the time, and learn how to say please and thank you very often, and don't talk back. If they say something rude to you, or something that you felt like was uncalled for, just take it. Take it and just be quiet, because it's not worth the fighting back or the standing up for yourself or saying, hey, that wasn't fair, that was uncalled for. Just don't say anything at all. Just take it, say yes, thank you, sir, and move forward. All right, fourth thing that I learned pretty quick, and I kind of knew this already, being the state political representative for my school. I already knew about kind of the politics that went on in anesthesia, but when you get into actual clinical practice and start seeing it firsthand, especially for people who don't know the background of the politics of anesthesia, you'll be enlightened pretty quickly that the field is very, very political. With all of this new stuff with CRNAs getting their doctorates now, and with all of these CRNAs who are popping up doing independent practices, having CRNA only practices, Medicare and Medicaid and all these different insurances trying to reimburse less and less and less. So anesthesiologists are typically making less money than they used to, and you're having all of this kind of turmoil go on with laws and legislation and stuff, and so you're going to sense that in the clinical field. You're going to step in, and you're going to need to be careful what you say, and what you don't say, and who you talk to about certain things and stuff. You're going to need to be careful how you introduce yourself. Some programs tell their students to address themselves as resident registered nurse anesthetist or something like that, because the reason they use that term is because when you say I'm a student registered nurse anesthetist, SRNA, which is a common term that a lot of people do use, the first thing the patient hears is I'm a student, and they immediately say, whoa, you're a student, and they think nursing student. They think you're in your first or second year at a community college trying to figure out how to be a nurse, and you're about to come in and do all this advanced stuff on them, and they're scared by that. So they don't like that idea. They think that you're a student nurse and that you're not trained. Then you have to go through a long process of have a bachelor's degree in nursing, and I worked in the ICU for years, and now I'm back in school, and I've done a year of didactic classroom training, and now I'm doing clinical training under the direction of a CRNA who's licensed or an anesthesiologist. So it's this long drawn out thing, and then they might let you do what you want to do, but it takes a lot of time. And I have found just myself, and I'm sure everyone finds this, it takes a lot of time to say all these things to patients, and if you do this over and over again throughout your day, it gets really monotonous, and it drains your time to do all this. So some programs tell their students, call yourself a resident nurse anesthetist, because they hear the word resident and they understand that means someone who is not a brand new student learning how to do something, who doesn't have any practice in anything. And so that's why they use that term. But there are quite a few people who do not like that term. They find if you use the word resident at all, even if you use the word nurse anesthetist after it, they don't like that term. They feel like it is just meant for physicians, and they will be upset if you use that term. And it's a very political thing about using that term. So I often just say I'm a student registered nurse anesthetist, and I then have to explain for 10 minutes on what all that means, which is fine because it gives the patient a background and an understanding to what CRNAs are. And then when I leave, hopefully they understand the details of everything that goes on with CRNAs and in our educational background. So in that way, it's fine, but it can be time consuming. So the whole point is it's political. You'll step into one clinical site, and they will encourage you to do central lines and learn regional blocks and do all the things in anesthesia that you're expected to learn and do and you're licensed to do when you get out of school as a CRNA. They will expect you to learn those things and do those things. And then there will be other sites you will go to, and that will be unheard of. Like they would be shocked to hear that you did blocks at another site, and they don't want you to do blocks there, and will be offended if you try and push to get to practice those things. So all of that is politics. It just has to do with that practice's certain political view on what CRNA should and shouldn't be doing. It's one of the very important reasons why I chose the program that I did choose. Because I knew that my program that I selected had a lot of clinical sites that did offer regional training and central line training and advanced intubation techniques, and there wasn't a lot of competition with. In fact, I think there's only maybe one rotation site we go to that has residents at all, anesthesia residents. So there's no competition between them and us on who gets the best cases. We get the best cases because we're the only students in most of all of our clinical sites, which is what you want. There's no need to compete between someone else on who gets the best clinical sites or who gets the best clinical cases. So anyway, we get a lot of our great ones, and we get a lot of practice with regionals and central lines and stuff. But even in our situation, there are a couple sites that we go to that are like big academic centers that are classic ACT models that are really restrictive, and as a CRNA you don't do regional blocks there. You don't put your own central lines in. A lot of that stuff is done by anesthesiologists. So anyway, it's very political. Know what you're stepping into. Know how to say the right things when you need to say it, and how to be politically correct when you need to be that way. And that way you don't ruffle any tail feathers of the people you're working with. All right, the fifth thing that I learned is that anesthesia can be mundane sometimes. I'm sure you've heard this from people before who say, oh, you want to go to anesthesia school, or oh, you want to go into that field. That I would never want to do that because it sounds boring. Everybody just goes to sleep, and you don't really get to talk to people or do much, and it's just sitting around watching people who are asleep a lot of the times. And there is some aspect of that that's true. But what I found is through the monotonous times where you realize, you look back over the last 50 cases you did, and you realize a lot of them went the same kind of process. Like a lot of them, you did A, then you did B, then you did C. Everything kind of progressed normally. Then you took them to PACU, and everything was okay. And so in those situations, yeah, you could maybe look at it and say, hey, that wasn't that exciting. But the good thing about anesthesia is there's always different places that you can do anesthesia that offer a different feeling. Like you can go do OB, which is a different animal than doing the OR, where you're doing, typical intubations and stuff like that. Or you can go and do a whole lot of regional. If you like pain management and regional blocks and things like that, you can go do epidurals and pain management blocks and stuff if you want to do those. There's pediatric cases. If you like pediatrics, that's a different animal. The dosages and the drugs and the way they react and things like that is very different than adults. If you like neuroanesthesia has a lot of different types of drugs you're going to use that are different from other cases. Certain drugs that you normally would use, you would never use in neuro because of the neuro checks they want to do and things like that. So that can add some excitement to it. Cardiac cases can have a lot of excitement if you like putting in PA casts and doing some of the more advanced cardiac stuff. The couple ones that I've been on as a first month junior have been exciting, and it's interesting, and they do acquire another level of like really focusing on every little thing that's happening around you. And even some of your normal cases can suddenly become bad in a moment's notice. And that's the 10% of the time that they say anesthesia providers are trained for, that the years of training you're doing is for that 10% of the time that things don't go as normal, things go wrong, something happens, and you have to be ready to, really respond immediately and know exactly what to do. Like say you're doing a exploratory lap or something like that, and it's a simple, normal, basic case. It should take an hour or two, and people get in and out, no problem. Very minimal blood loss supposedly, and the surgeon nicks an artery or a vein, and the patient starts to bleed out. And then as the patient's bleeding out, you're realizing you've been giving with your anesthesia meds and volatiles and stuff a whole lot of cardiac depressant type drugs and a lot of things that are suppressing the cardiovascular system, which now the patient needs that system to compensate for the blood loss. And you're depressing it, so you have to slow those things down to help not depress it as much. And now the heart rate's shooting up, and the sympathetic nervous system is on overdrive. And now they're pumping blood out because their blood pressure is too high, and they're pushing blood out of that broken vessel too fast, and they're hemorrhaging out internally. You're calling for the blood bank to hurry and get there and get blood so you can transfuse it, and you're trying to help the surgeon whatever way you can because they're trying to do an open case all of a sudden and try and get that bleeder to stop. And at the same time, the patient's starting to wake up because you're turning down your gases and stuff because of the cardiac effects, and now they're waking up and bucking the vent and moving, and blood's gushing out of the stomach because their abdomen's moving with the pressure of breathing against the vent. So there's just a lot of things that go on in anesthesia that you have to think of immediately, and it's all up to you. The surgeon's job is to surgically do whatever they're doing, but everything on that patient that's going on hemodynamically, bleeding and vital signs and breathing and all of that is all your responsibility. They have nothing to do with that. They look over at you and say, is the patient okay? And they're expecting you to say yes. And if the patient's not okay, it's your job to figure out how to fix it through drugs or blood or whatever you have to do. And if you have to tell them close up and stop the case because there's no way you can continue forward or something, then you have to tell them that, and sometimes the case gets canceled. But anyway, my point being, it can be mundane sometimes, but it can also be very exciting at other times. And there are different areas of anesthesia you can kind of cross-train into and go into so that you can always keep things a little bit interesting if you want, so you're not doing the same type of anesthesia all the time. Well, guys, I am running a little long here, so I'm going to wrap up. Those were 5 things that I learned in 6 weeks of starting anesthesia rotations, and I thought you guys might find it interesting. If you guys are in CRNA school too, or maybe your residency for anesthesia, and you're learning some things as well, post in the comments below and let me know what you guys think. And if you're trying to go into CRNA school, did you find these 5 things something you already knew, or is this new information for you? I also want to tell you guys that I am not posting as many videos as I used to, as you probably noticed, and that's partly because of school ramping up and partly because of the time constraints with as much schools that I'm doing, and the time to edit and to put together these videos. It can be time consuming. So essentially, for time management reasons, I'm not being able to put out as much videos on YouTube as I'd like. But what I am doing as a compromise is I have my Instagram page, which is Bolt SRNA, same as the YouTube page. And I am doing some like live videos sometimes, and I do like little clips throughout my day of like when I'm in the OR, and of course nothing that violates HIPAA in any kind of way, but it's just simple goofy things here or there to kind of let you see what the normal day-to-day life of a CRNA student is like. And so if you guys want to hit me up and follow me over there, you can, and you can kind of get some glimpses of the normal SRNA life over there. And also, if a lot of you start asking and requesting, there's this thing that a lot of people are doing on Instagram now with it's like a live chat type video where you live chat and the audience tunes in, and then they can comment and stuff, and you can interact with them. So if there's a call by a lot of you to do that, then I would consider doing that in the near future, so that I could kind of interact with you guys and answer some of your questions live, immediately, and interact with you. So just looking to be a resource for you guys when my time is available for me to do it. But anyway, that's it. Bolt out.